Hi, this is Khaled Shebani. I am a board certified surgeon. I've been practicing general and bariatric surgery since the year of 2005. We'll talk about the generous scope and the services offered by our practice. We perform the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, and the revision conversion of failed lab bands. All procedures are performed laparoscopically. We also perform both diagnostic and therapeutic upper endoscopy. We take care of conditions such as bleeding ulcers, strictures, and also we provide the sclerotherapy for those who gained the weight after Roux-en-Y gastric bypass. You are not alone. Obesity is a worldwide epidemic that affects men, women, and children. It is the leading cause of preventable death. There has been estimated 112,000 obesity-related deaths every year, and in 2012, the prevalence of obesity was 20% or higher in all 50 states. Obesity is a complex disease. There is a misconception it's caused by overeating alone. It has many causing factors, including genetic, psychological, and cultural. Cheap and abundant fast food, along the use of high fructose corn syrup and virtually all the foods we consume, along with a sedentary lifestyle, have led now to the development of the obesity epidemic. BMI is measured by dividing the weight in kilograms by the square of the height in meters. The normal range 18.5 to 24.9. Morbidly obese is 40 or higher. Super obese is 50 or higher. Super obese is 60 or higher. We'll talk about the comorbid conditions or diseases associated with morbid obesity. We'll start with the definition of the metabolic syndrome, which is a combination of at least three of the following conditions: abdominocentric or central obesity, hypertension, prediabetes and diabetes, high triglyceride serum level, low high density lipoprotein or HDL, also known as the good cholesterol. Obesity negatively affects the cardiovascular system. It results in hypertension, atherosclerosis, resulting in ischemic heart disease, and or peripheral vascular disease, congestive heart failure, and sudden death. Obesity can also lead to deep venous thrombosis or DVT, chronic stasis ulcers, chronic lymphedema and elephantiasis, pulmonary embolism originating from the deep venous system that can lead to death. Diabetes is one of the most common conditions associated with morbid obesity. Type 2 diabetes, to be specific, with impaired glucose metabolism, insulin resistance, and in the early stages, pre diabetes. Gynecologic disorders. Now, it's 80% of the obese women are in the childbearing age. Polycystic ovary and anovulation, sterility, menstrual cycle abnormalities such as heavy menstruation or menorrhagia, or cessation of menstrual cycle or amenorrhea. Pulmonary disorders such as obesity, hypoventilation syndrome, sleep apnea, adult onset asthma, chronic obstructive pulmonary disease or COPD, digestive system disorders such as gastroesophageal reflux disease or GERD, fatty liver, non-alcoholic steatohepatitis or NASH, liver cirrhosis, gallbladder stones. Obesity negatively affect now the weight bearing joints, including the spine, leading to spine osteoarthritis, knee and hip osteoarthritis, and oftentimes we see that the patient is denied having joint replacement, and the fear that the overweight will cause failure of the prosthesis. Another aspect of the negative effects of morbid obesity is social and psychological disorders such as workplace discrimination, difficulty in some public transportation, hygienic difficulty, abuse, acceptance, poor self-esteem, and confidence that can lead to clinical depression. Many treatments of morbid obesity have been tried in the past, including weight loss programs through diet and exercise, appetite suppressants, hypnosis, behavioral therapy, uh, even jaw wiring with 95% failure rate. And oftentimes we see patients lose and regain the weight, and that's a very common scenario. In 1978, no, the expert panel and the National Institutes of Health came to the consensus that surgery is the most effective treatment for morbid obesity. Um, you have to remember that surgery is only a tool and is the last resort option. Behavioral modification and dietary compliance is imperative for the long-term success after any weight loss surgery. In order to better understand the different types of weight loss surgery, we divide them into three categories: malabsorptive, where now the digestive tract is shortened and rerouted, so less nutrients and calories are absorbed. Restrictive reduces the amount of food that the stomach can hold. And then the combined procedures with the both approaches are combined. For historical purposes, we'll briefly talk about the jejunal bypass was practiced in the 1950s and 70s. It was associated with major problems such as bacterial overgrowth and the excluded or blind loop of the bowel, led to kidney stones, renal failure, acute liver failure, and irreversible liver cirrhosis, and was basically abandoned in 1974. In the restrictive category, we have horizontal gastroplasty, the vertical banded gastroplasty or VBG, the adjustable gastric banding. We only perform vertical sleeve gastrectomy or VSG in this practice. The first two procedures has been abandoned and they are no longer practiced by weight loss surgeons in the United States. We'll talk briefly about the adjustable gastric banding. It's been approved by the FDA since 2001. It's technically less demanding on the surgeon. There's a modest weight loss in 5 years. Frequent follow-up is needed. Strict self-control is also needed. Failure to lose weight, slippage and erosion, in some studies up to 30% has led to the fact it's falling out of favor among surgeons, and we do not perform this procedure in our practice. So in the combined category, we have now three procedures: the biliopancreatic diversion, with or without duodenal switch, and we only perform the Roux-en-Y gastric bypass in our practice. We'll talk briefly about the biliopancreatic diversion, where the distal part of the stomach is removed. The remaining of the stomach is connected to the lower intestine. Technically, this is a very difficult operation and should be performed in a academic or teaching hospital setting. There's a higher incidence of malabsorption of micronutrients such as vitamins and trace elements. Another operation is the biliopancreatic diversion with duodenal switch, where part of the stomach is removed. Gastric sleeve is created, and the pylorus is preserved in this operation. The small intestine is reconnected downstream. Again, it's technically more demanding. There is a higher incidence of micronutrient deficiency compared to the gastric bypass. So we perform three procedures in this practice: the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, conversion of lap band to either vertical sleeve gastrectomy or gastric bypass, and all procedures are performed laparoscopically. The Roux-en-Y gastric bypass has been in practice since 1982, so we are familiar with its outcomes and potential complications. It is the gold standard in weight loss. It provides faster weight loss, faster comorbidity resolution. Technically, it's more demanding than the gastric sleeve, and that translates to higher risk of complications. We will see an animated video how the surgery is performed.
Access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
The vertical sleeve gastrectomy is a relatively new procedure since 2007. It's purely restrictive. Now it's about 85% of the stomach is removed. It provides a slower weight loss and resolution of comorbidities. Technically, it's less demanding. That can translate to lower risk for complications. We will see an animated video that demonstrate how the procedure is performed.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
There's rather an impressive comorbidity reduction after bariatric surgery. To the left, we see the Cleveland Clinic study. We'll talk about the Buchwald and colleagues study in 2004, which shows improvement or resolution of diabetes in 86% of the patient, dyslipidemia, now it's 70% of the patient, hypertension, 78% of the patients, sleep apnea in 86% of the patient. This was a comparative analysis of different outcomes from independent studies, hence the term meta-analysis is used. We'll talk about some of the potential complications after bariatric surgery. Anastomotic and staple line leaks, these are one of the most serious complications that can lead to generalized infection or sepsis, multiple organ system failure and death if left untreated, strictures, ulcers, and perforations. We insist that the patient Stop smoking and avoid any non-steroidal anti-inflammatory drugs. Wound complications, including wound sepsis or the infection, dehiscence, later on incisional hernias, myocardial infarction or heart attack, deep venous thrombosis (DVT), and lung clots or pulmonary embolism, failure to lose the weight and weight regain later on, a lifelong adherence to um, diet and exercise regimen is a must. Nutritional deficiencies, patient also has to commit to a lifelong commitment to take their supplements. Why minimally invasive surgery, whether it's laparoscopic or robotic assisted and not open surgery? Less bleeding and potential need for blood transfusion, better pain control, faster recovery, earlier discharge from the hospital, and earlier return to normal activities and work. Less wound complications, including wound infection or sepsis, dehiscence, and incisional hernias later on. Better cosmetic results with a less and smaller scar. The correlation between the surgeon's experience and the morbidity, mortality, and complications related to the surgery is well documented in the medical literature. Once the surgeon has performed 250 weight loss procedures, the rate of the mortality and complication should be less than 1%. Now, the ultimate question is what operation is best for me? I always tell my patient, do your research. An educated and informed patient will make the best decision. Don't be afraid to ask your surgeon about their outcomes, complication rate, and their approach to surgery, open versus laparoscopic. Also, long term care and support groups. Be prepared. Stop smoking, eat healthy, and when feasible, exercise regularly. Remember, surgery is only a tool. You have to work with it in order for it to work for you. Who covers the surgery? We accept self-pay with our cash or the credit. Private insurances, except if the patient's policy has an exclusion. Medicare and Medicaid cover all surgeries and office visits. How do I get started? Call our office today. Get a referral from your primary care physician. Avoid delay. A documentation of a 6 month supervised diet and weight loss plan with no gaps, with monthly weights and visits, is required by all insurances. Also, ask our staff about the other requirements list. It's long, but we'll get you through it. I hope this was an informative presentation. Thank you for watching, and please don't forget to check our live videos on YouTube and Facebook.